very hot topic. I have 15 minutes to do this. So here are my disclosures really quick. So we know these are problems. We're talking about kidney cancer. It's a world problem. We know these numbers to just kind of get set the bar here for us. And we're talking, everything I'm going to talk mainly today is going to be about clear cell RCC. So with that said, just a reminder, the reason why we're asking the question is because more people getting adjuvant therapy. And the reason for that is because at least half of the folks consider high risk for recurrence. The idea is we don't know who they are. Can we minimize their risk of recurrence? Can we do something else? And I think we all know the data around 564, the role of adjuvant immunotherapy, in this case PD-1 inhibitor, pembrolizumab, against standard of care, which was placebo in this particular trial. I think we all know these results. It statistically delays time to more disease in the scans, or disease in the scans, defined by disease-free survival, and also overall survival. This is data for 5-year follow-up. Great job from Naomi. Just presented this last ASCO, so we know these results. Actually, when we were looking at these data the first time around, about a year or two ago, there was a question coming up about, well, listen, is everybody getting a checkpoint inhibitor upon progression? Because the question is always now or later, and a lot of times it's actually now or never. So there's actually a study, it's not published yet, but we basically went to see of all registration trials that approved immunotherapy in GU, you see kidney cancer on top and urothelial carcinoma on the left. You're basically looking at what happened to the control arm. The patients did not get immunotherapy on the comparator, and how many of them end up getting immunotherapy upon progression. So try to answer the question, is this really a question of now or later, or is the question at times to be now or never? As you can see there, a lot of these studies are actually international studies. Access to therapies is not the same, as you know. So you can see those numbers are not 100%. And these are just people who end up getting something upon progression. And so keep that in mind. So some of these numbers actually get very close to 50% or less, right? So it's just a reminder that we have that philosophically comment that we can make about, does anyone will get that therapy at some point, in this case for advanced disease. Just as a proof of point. Now, everything I'm going to show you is not level 1 based, and that's probably one of the key messages from these little talk. So this is an algorithm put together, ASCO Daily News, Maria Burlon, fantastic work, Mexico, work with Tony and put kind of this setup. And what should come up from this schema is it matters when you recur, it matters how you recur, and also matters the options we have available. So I'll try to address a little bit of that. So the first thing is when we have recurrence, meaning when cancer comes back, I think it's common sense for us to think, well, Pedro, it's different if cancer is coming back with one spot or is coming back with disseminated metastatic disease, right? It makes sense. You would say, well, it also makes sense if patient, if you have recurrent disease, 6 months after you've completed a year of pembrolizumab, or if disease comes back with multiple spots 5 years later, right? Intuitively, we would say those are probably different patient scenarios, and there's probably different biology. So the first thing we try to answer the question is, if I see a recurrence, do I need to treat? That's one question. And the other one is, okay, if I do treat, can I consider local therapy? And this slide is, we actually can apply this for post-adjuvant or metastatic RCC for patients who did not receive prior nephrectomy. So you always got to think about those things. So what does that mean? So going back to the keynote 564, you can appreciate that, and keep in mind, people who end up getting something, who got recurrent disease, you had about 226 patients on the placebo, right? So of that group, less than half end up getting systemic therapy. What's interesting to me is you see about a quarter, or close to a quarter of patients getting local therapy with systemic therapy there, about 24% or so, just focus on the placebo group, if you will. And then you can see of those who recur, about half, 109 patients out of the 226 end up getting a checkpoint. So there's something about this that tells you that we are addressing the patients who progress after radical nephrectomy, and we address them differently, right? If you want to change your mind, go back to the pembro arm, people who received adjuvant immunotherapy, and you can see that less than half end up getting systemic therapy. So of all who recur, you see that 171 patients who recur, about 73 patients received something systemically, whereas 37, 20%, 1 out of 5, received local therapy. So I'm trying to make the point is, it goes beyond the question, oh, what do you do for a patient who receives Pembro? And so keeping those things in mind is relevant. And the challenge will be, how do we develop data for us to support? We certainly should do A, B, or C. So I'm going to do my best to do that. So what do we know from metastatic disease? Well, we know that if you decide to treat someone, then you're going to consider an IO-based combo for the majority of patients who are IO candidates, whether you do a dual IO, whether you do an IO TKI, and then for certain selected cases, we could debate very good risk, et cetera. Are you still going to do a TKI monotherapy? So in theory, that's what we have. Okay, so the next thing we could look at is like, okay, so if I'm recurring post-Pembro, perhaps I should look at data post-immunotherapy, right, and see what happens there. And when you look at the options for prior IO, you have a list of therapies, for the most part, that are target therapy, monotherapy. So that's coming from. So I try to put together a couple of data sets that basically show us some data post-PD-1 progression, right? And this, as you can see, is for the most part is monotherapy. LAMP-AV was actually before IO, so that as a refractory setting doesn't count for what we're mentioning. I like to highlight the work from the Europeans a lot. This is work from Lawrence. I think we have seen this, post-IO-IO or post-IO TKI. You can see Cabo is active. So for most of us, when you're progressing relatively quickly, I'll get to that point what that means, I think most of us would consider TKI monotherapy would be the standard, right? If nothing else, that's probably what I'm going to do. You can see there's activity. It's not really surprising. We know this. We've seen this over and over again. So then, of course, I'm biased. I was there when we were enrolling for the AXI post-IO with Brian Rini. Then he left. Moshe took over, and we basically see activity of axitinib. So the message is, for those who are less familiar with kidney cancer, the first TKI. So the activity of TKI is dose-dependent, and usually the first TKI use gives you the best money for the buck. So in other words, it's the one that tends to work the best. But with that said, you can see activity with axitinib. And so the next question is, okay, I get it. So if the standard is a TKI monotherapy, what about checkpoints? Because checkpoints are different. I have PD-1s, PD-L1s, CTLA-4. So for a long time, I think, I would argue, we were very excited about doing ipilimumab at any point, right? I remember that it's probably, 2017, after Ipi-Nivo was presented by Bernard, then all of us were trying to do Ipi-Nivo everywhere, right? And so we had a bunch of data sets that trying to answer that question. Even in the salvage frontline, so people getting Nivo up front, if you salvage them with Ipi, or later on for patients who receive a PD-1 or PD-L1 before. As you can see by this table, that excitement kind of went away, right? Responses are limited. There's always a few patients who are going to respond very nicely. Most patients is fairly ineffective. So there's a limited activity of that. So we kind of moved away from that excitement, where we're doing it to everybody, to start doing it to selected cases. To then ask the question, well, sure, but that's for IO-IO, or that's a CTLA-4 PD-1. How about an IO-TKI, right? The IO-TKIs were emerging in a frontline setting, Axi-Pembro, LENP-PEM, Cabo-Nivo. What about doing it later on? So, and based on that data, it was actually phase 2 from Lee at Sloan. He ended up moving to industry, and you actually have a proof of concept. Here's, 108 patient, a Lancet paper, Keynote 146, and just a reminder, over half of the patients end up responding on LENP-PEM. So at least it's generated the excitement to do, you know what? We need to validate that question. Should we do an IO-TKI for people who progress on a prior IO? And I think I'm not going to tell you anything surprising. So we have actually 2 phase 3 trials, CONTACT-3 and TiNivo-2, to ask that question. So these trials are not exactly the same. There are some nuances that I like to remind myself when we talk about this. I was involved in the second one, not on CONTACT-3. I'm a co-author on TiNivo-2. So one of the important differences is obviously, on the CONTACT-3, you keep the same dose on both arms. It's actually the first study that really addresses the question around contribution of components, which is a regulatory term to understand what is the additional benefit. So if you're going to compare to the addition of IO, this is the only study to that point that was actually using the same backbone therapy on both arms. So that's a detail. The other detail that's relevant, these patients needed to be progressing on a prior IO in the last 6 months. That's not true for TiNivo-2, but it was real for CONTACT-3. Right? So with that being said, we all know this is a negative trial, but the other piece of the story in TiNivo-2 obviously uses a PD-1 inhibitor, not a PD-L1, with I think PD-L1 in the GU world got bad rap, right? It became like, well, we're not sure Tizo is that good as PD-1 inhibitors. So Tinivo got that merit. However, I thought it was going to be positive, to be frank, and the reason why I thought it would be positive or could be positive is because it did not mandate progression within 6 months. So you could come up with that concept of, well, you know what, give a break to the immune system, and then maybe you can salvage those patients better later on, because you did not mandate that on the trial. The problem was when the Data Safety Committee looked at the data initially, there was issues with the safety of Tiva 134 with Nivo. So what happened? On the combination arm, you lower the dose of tivozanib. So you go with a lower dose of TKI with Nivo compared to a full dose of a TKI. Now, I'm not saying that's why it's a negative study, but when we look at these results, we absolutely accept the idea there's nothing there. So the excitement initially on the CTLA-4, for the most part, was really going down, and then the excitement around PD-1, L1 based salvage approach also went away. Just a reminder, this is not pure for post-adjuvant. I'm borrowing the data. For the most part, metastatic disease, we have a little bit more on Tinivos than on CONTACT-3, but that's the data we have, right? So, and why is that? Well, because we're not using pembrolizumab adjuvant for a long time, are we? And we really need longer follow-up. So as time goes by, we're going to start seeing designs to answer the question about adjuvant, but this is the best data we have, perhaps, to try to answer that question. Then one could argue, okay, so I get it. So we explore CTLA-4 in the salvage setting. We explore TKI-IO in the salvage setting, post-IO. How about other approaches? I go after Keymaker 03. Kathy did a great job. I believe Christina Suarez also involved in this design. And the reason why I like this is because it gives us a sense for people who progress on prior IO, combinations where we're all asking the question daily basis. One is with a HIF inhibitor, belzutifan. Another one is obviously with lenvatinib pembro, which, I guess we could look at that data from the other data from Lee that I showed you, and also lenv-bel. And that's an exciting topic on the side, not for this talk, about how does lenv-bel performs against Cabo, and that trial, we'll see what happens later this year. But I would argue, if you start looking at the numbers, I think it's fair to say it's probably not much there, right? I think there's all the sense in the room when this was presented. It was like, well, lenv-bel seeing 12 months PFS, it's not that different from what we would expect. So maybe this is the glimpse why some of us think that the lenv-bel combo might not beat Cabo. We'll see what happens there. I don't know. But the lenv-pem 9.4 months, we would argue that's kind of what I would expect lenvatinib by itself, right? So it's definitely not something I will see here and say, oh my God, this is it. And by the way, the data for PFS for Bell with 5.4 months, just want to remind you, that's very similar to the 5.6 months on LIGHTSPARK-05 that compare belzutifan against everolimus. So what I'm trying to say is, at least based on these data, obviously small groups, it does not suggest that the addition of IO to at least a HIF inhibitor in TKI, it's anything there. So I don't think we're ready for prime time from that perspective, insisting on a salvage IO. So what do we have based on that? Well, this is actually a great job by European friends and colleagues, I think this paper is known to many of you, and I kind of highlight some of the concepts because after everything I showed you, I liked showing you any level 1 data to support doing something. Yes, we have CONTACT-3 and Tinivo, which tells you not to do something perhaps, but I don't really have data to show you what to do, right? And so this is actually consensus level recommendation, if you will. So I think we all accept the idea that if you progress within 6 months, you consider almost primary progressor or forget the IO. I think we also understand the concept that in some cases, active surveillance of not starting systemic therapy right away, it's a good idea, as you can see there. And then we debate, when should we consider an IO-based approach again? Some would argue it's 12 months. Some would argue it's going to be 24 months or later. I don't know that, but what did I do? I just pulled the frontline studies quickly that are going on right now in the future, and I actually check it out. And actually I pulled all the protocols for this. Cosmic 303 obviously read out, Cabo Ipinevo versus Ipinevo. Actually took patients post 6 months. I would argue it's actually one of the shorter. But actually, even CARE-1, is also taking patients post 6 months. We'll see what happens there. Obviously, a big European study. Spain is part of that. But then LIGHTSPARK-12, as you can see, and the EVOLVE, is really, the LIGHTSPARK's taking a year minimum. And in our own study, with the CBM 588, we're going to be taking a year as the minimum time to go back on an IO-based approach, as you can see, and finally evolve. For now, they're not allowing the combo in that particular trial. That's the AstraZeneca sponsor study. So this is what we have. So the reason I bring that up, because I don't think we're going to have a definitive answer in the near future regarding should we use IO in the salvage setting. So I really think that we're going to be playing with TKI monotherapy, or at least a non-IO approach, unless something else comes back and as a combo regimen, perhaps, and will beat what we have as TKI monotherapy. So here's my summary points from everything I said. Obviously, I think we will continue to rely on our clinical acumen of saying it does depend, the prior therapy, sites, pattern of recurrence, timing of relapse. I think there's a limited role for salvage immunotherapy. I think it's fair to say that less than a year, we're probably most of us going to be offering TKI monotherapy. Late relapses, I think a lot of us are actually going back to an IO-based approach. I also think that the management is actually not based on level 1 evidence, and a lot of what we're doing is expert-based and level 2 data for the most part. And also the question around access is relevant. Remember, not always is now or later, it's now or never, right? So you always need to take that in consideration, if you will. So that's all I got. I appreciate that. Muchas gracias de estar aquí con vosotros. Gracias.